March is Women's Health Month, so we thought that it would be fitting to host a panel discussion on the topic. Hello, my name is Mike Whitmer. Chiropractors face a variety of women's health issues in their practices, so we've invited a few experts in the field to discuss this important topic with us. To lead our discussion today, it's my pleasure to introduce our moderator, Lori Holt. Lori has been with NCMIC for many years as a corporate relations representative, and many of you have probably met her as she travels around the country representing NCMIC at association and college events across the profession. Lori is a registered nurse and worked as a nurse in a variety of settings for 30 years. So Lori, thank you for helping us with this topic. And with that, I'm going to turn it over to you to introduce our panelists.
Thank you, Mike. First, I have to say before I introduce our panelists, yes, I have been nursing for 30 plus years. I started at the age of 5. So that tells you how old I am, but no, really. I do want to introduce, it's my pleasure to introduce our panelists today. First, I'm going to introduce Dr. Kris Petrocco-Napoli. Her interest is women's health, especially related to natural health care plans. And this has been her focus for 2 decades. She's been actively involved in research related to pelvic pain in females and has authored both clinical and educational articles on the topic. Her practice and research centers on chronic pain, the female population, lower extremity amputees and gaits, and integrative collaborative practices. Dr. Kris, welcome.
Thank you.
Our next is Dr. Georgia Knabb. Dr. Knabb currently owns Authentic Life in Shawnee, Kansas. What is that one?
Shawnee.
Shawnee. You would think with my draw I would get that one without any problem, but there you go. A clinic that focuses on functional medicine, genetics, nutrition, and chiropractic for its patients. Dr. Knabb also writes and speaks on health topics around functional medicine, genetics, nutrition, chiropractic, and lifestyle. Dr. Georgia, thanks for being here today.
Thanks, Lori.
So I think what we'll start with is, the new year is almost 3 months behind us, but every January, I don't know about y'all, but I know about myself, I make these plans to lose weight, and it lasts for about 8 weeks, and then I'm done with that. So I think we'll start that off because a lot of women are interested in that, and see how we can educate our doctors to help us as women to actually become more healthy. So my first thing is, and I think this aggravates me, men lose weight faster than women. That's not fair. We're the ones up doing everything. So with the focus and respect to weight loss, what is a healthy pace for women to actually lose weight? Who wants to take that one?
I can take that one.
Okay.
So I think a healthy weight loss for women is somewhere around a half a pound to a pound a week. And I know that sounds slow, but what I tell patients is the key to losing weight is balancing the hormones, and that the weight loss is a side effect. That when they can't lose weight, they've got hormones that are out of balance. And until we get those hormones back in balance, the weight is just going to hang on. And if we compound that inability to lose weight, those imbalance of hormones with an autoimmune, that can make it even harder to lose weight. And so you take those two things in context that, well, we see autoimmune far more in women than we do in men. Mm-hmm. And we have far more hormone imbalances in women because we have so much fluctuation with our hormones. Those two alone make it more of a challenge, but not impossible. I mean, that's the thing to stress is it's not impossible, but let's focus on balancing these hormones and think about weight loss in terms of, I just want to be a healthy me.
Mm-hmm, mm-hmm.
Dr. Kris?
Yeah, yep. What's your thought?
Yeah, I agree with Dr. Knabb, and I think the other thing too is sometimes women are a little bit harder on themselves. Where Dr. Knabb just said a half a pound to a pound is average for women and healthy for women to lose. And I think that with that being said, we're a little bit harder on ourselves when we're not losing a lot of weight and we're wanting to take things a little bit faster than we should. I also think it comes down to de-stressing ourselves too, right? Hormones have so many different components and so many different effects. And if we have high stress levels and we're not focused in on taking good care of ourselves, that's also going to be a contributor. So.
And I'm just going to bring out a point here. You know, there's so much on television that we see, or just in talking with each other. To me, I call them fad diets when we're talking about, you know, Atkins and those that are out now. And, you know, I have to say, I did not research them, have not researched them, but both my husband and I tried Atkins, and he pretty much told me that I needed to eat in about the third day, or he was going to put me out in the garage somewhere. So what, Dr. Nab, your thoughts on that? I mean, is it a healthy way to go when we're talking about fad diets and adding in good nutrition, or should those be avoided all the way?
You know, when I talk about diets with patients, I try to avoid the word diet and I try to use lifestyle. That I want to focus on foods that are healthy for them and the lifestyle that they want, that they can maintain for long term. So my concerns, a lot of times, you know, ketogenic is a big one out there, right? A lot of people stress, oh, just do the ketogenic diet. Well, you know, for women, the challenge with the ketogenic diet, with a lot of my patients anyway, is that one, they either have had their gallbladder removed or they've got a really sluggish gallbladder. So when they're eating all these fats, they can't digest them and they actually gain weight on the ketogenic diet. And it goes again back to these hormones that we've got to have a healthy liver, healthy gallbladder. If they don't have a gallbladder, let's figure out how do we nutritionally support that gallbladder. And a ketogenic diet oftentimes isn't ideal for them. The other thing with the ketogenic diet that I see is that when they're doing a ketogenic diet, they're doing it in a very unhealthy way, that they're doing a tremendous amount of processed fats that are just clogging up their whole system. And so I do a 6-week keto green class that I offer my patients that stresses, that can put them into ketosis, but the real focus is on the greens, that we can still get into ketosis, but we can really focus heavily on these green vegetables. And I have a food list for them and recipes that are fairly easy. And I work them into it, that we don't just jump right into that with my female patients. I get them to a place of where their liver and their body is ready for it. And then we put them into a ketogenic diet, if that's the right diet for them. But it's not the right diet for every woman. So the diet that I recommend to my patients, it's very individualized. And it's really, again, focused on getting these hormones healthy.
Absolutely. So Dr. Kris, Dr. Nab has talked with us about doing the hormone healthiness and all, you know, how she does care plans for her patients, which I think is great instead of doing just one for everybody. So if a patient is having problems still losing weight by diet and exercise, is there anything else that a patient could do outside of Dr. Nab's suggestions?
I wish I had the silver bullet answer for that one. You know, because that's often asked, right? Patients come in all the time, doc, I've been dieting, I've been exercising, I've been looking at, you know, everything under the sun, right? They can give you the whole list of things when they come in and talk to us. And, you know, I really do think it's individualized. I really do think one of our greatest skills as chiropractic physicians is to look at the patient from the whole aspect.
Absolutely.
Right. And I always say, you know, what else is going on that we might be missing? You know, is there, and I keep going back to the stress component, but you know, that seems to be a very significant thing in a lot of our female patients. You know, and there's also the other screening questions that we ask in our history. You know, how is your mental health? How are you sleeping? Right? Sleep is another big component that we know that impacts metabolism. You know, our chronic pain patients, if they're still going through this and they're not sleeping well, they're not eating well, and they're trying to lose weight and be healthy at the same time, there may be something else underlying. So again, that history component is huge. And, you know, I wanted to jump off of something that Dr. Nab said. She mentioned the gallbladder, right? And a lot of times our patients don't think to tell us that they have their gallbladder removed if we don't ask. And so if you're talking to them, especially women, we know that sometimes too the gallbladder can be a source of housing estrogen. And so a lot of times when it's removed, there becomes a whole nother component related to that. So when we miss or don't ask that question, we can be missing a lot of different things as it relates to coming up with that correct treatment plan for our female patients.
And
Can
so,
I add
yes,
into that just a little bit on the gallbladder? You know, who's the most common type of person to have their gallbladder removed? Well, it's a woman in her 40s who's overweight, who's having a lot of hormone issues. And so what happens here is that this type of woman is she's having some hormonal changes as the ovaries are beginning to shut down and the adrenals are supposed to kick in. Well, estrogens tends to be in excess in these women. Well, what does estrogen do? Well, it thickens the bile, the bile, from the gallbladder. And so that thickening, and oftentimes they can develop stones from that. And what is what's traditionally done? Well, we'll just take it out. Well, no, wait a second, right? Let's get these hormones back in balance and use natural things to kind of thin the bile down so we can get these lipids moving, get rid of these estrogens so that these female patients can keep their gallbladder. It's really heart-wrenching when I think, oh, we could have, if I'd only known, right, we could have saved your gallbladder. And it's really interesting because one of the simple things that I tell patients that thins the bile is coffee. You know, sometimes coffee gets a bad rap, good or bad. But I tell my patients coffee, not in excess, but no more than 2 cups. Coffee has the effect of thinning the bile down, and it's rich in antioxidants. So it's actually really quite good for your liver and your gallbladder. And I encourage them to drink it black. Don't put all this stuff in it. Just drink it, a good black coffee, to help keep your gallbladder and your liver flowing and to help support it. And tangent off of that, we can talk about enemas, but a coffee enema can also be effective in helping to thin the bile and support the liver and the gallbladder. So back to you, Lori.
Okay, so I just lost track of thought. So if a patient is following, we've talked about hormones, a little bit about nutrition, but if a patient is following exactly the care plan that you have put for that patient and still not losing the weight that you as the doctor feels that they should be, what are some other symptoms as far as the endocrine, that kind of thing, that maybe you could rule out for that patient to see if there's a problem there that's causing the weight loss not to be like it should be?
To me, if it hasn't been checked, and I always check, because autoimmune is huge and it's one of my specialties, so I'm automatically checking for autoimmune. But if they have autoimmunity, it can take 3 to 6 months before they start to really realize some weight loss. But the other challenge is if they have insulin resistance, which is pretty common, metabolic syndrome, that also can take 3 to 6 months to get those hormones back into balance before they'll start to realize weight loss. So those are 2 biggest factors that I see that slow down or even halt weight loss, and it's all about hormones. Yeah.
And I think there's something really important as practitioners that we have to remember, and so a lot of times female patients in their 40s and close to their 50s will be like, oh, it's just perimenopause or menopause. Or they've been to a provider that's kind of dismissed some of their symptomatology, telling them this. And so I think it's really important that we encourage them as we're helping them and we're guiding them, that we educate them on, it may not just be menopause or perimenopause, that it could be your thyroid or metabolic syndrome or insulin resistance, and help to encourage them to learn about all of the different components and also advocate for the care that they need and deserve and want,
right.
Especially as they're moving through this.
Right. Well, and now let's get to exercise just a little bit. I'm kind of gung-ho when I'm actually exercising. It's like all or nothing. But there's some people who really don't know where to start because they haven't exercised in a while. So what would be some suggestions that you would give your patients to safely start exercising instead of, going out there and try to flip a tire or something over.
Oh.
You mean that's not a natural way to start, Lori?
Well, yeah, I'd have to work up to that just a little bit, I think.
And I think you raise a really good point, because every female has a different story on what their day looks like, right? Whether it's kids or caring for parents, or having a job where they're there long hours, and so finding that time is the first piece, right? Really identifying, okay, when can I fit this into my schedule, and what does it look like? I think my first recommendation to patients a lot is, don't start something that you already know you're going to hate, right? When patients say, I hate going on the elliptical, so I forced myself. Well, don't do that, right? So I think the recommendation to patients is, well, what do you like to do? And, it could be as easy as going out and walking, trying yoga, looking at different ways to, move through and do Tai Chi if yoga is not for you. Swimming, and just really giving them options. But I always say, go with what you're going to like. Don't force yourself into something that you already know is going to be something that you're going to not be motivated to try.
Well, for me, I don't use the word exercise in my office unless they come in and tell me they are exercising, they're pretty active. But for this general patient, I don't use that word. I talk to them about movement. Because to them, if I say the word exercise, then they're going to think immediately, they're going to think I'm going to tell them they need to be in the gym for an hour, 3 to 5 times a week. And, immediately that wall comes up. So when I talk about movement, then they're like, what do you mean movement? And if they're not used to moving, I start them with 5 minutes in the morning. And what that means is when they get up in the morning, they go to the bathroom, and then they get their cell phone and set it for 1 minute. And then I teach them, do something for 1 minute that gets your heart rate up. That might be doing modified jumping jacks. That might be doing some like running gently in place, whatever it takes to get their heart rate up for that 1 minute. And then they walk and get their heart rate back down. And they start by doing that just 3 times. So that's 5 minutes. That's all. And I have them do it, just start Monday through Friday, because most people are working. So we start Monday through Friday. You're just going to do 5 minutes. And then as that gets easier, I push them to go now 7 minutes. Now go a little bit longer. So one of my patients that I had, she was mid-60s and hard time walking. She was only 5 foot, 268 pounds. So she's got a lot of weight that she was carrying. And I started her with just the 5 minutes in the morning. In 1 year, she went from 268 pounds down to 218 pounds. So she was down 50 pounds. And instead of 5 minutes, she was at 45 minutes of movement a day. Again, we never use exercise, we use movement. And this was the key thing that I focused with her on. So when you start small with these patients and allow them to do what they do and just gently push them, it can make a profound difference in their movement, because you can imagine how much better she felt.
Oh, absolutely.
I don't know if I was offending her, but I said, think about that. That's a big old bag of dog food that you just dumped off your shoulder.
And congratulations to her. I mean, that's awesome.
And she kept it off, because now we had developed this habit with her of gently moving, and it was a habit. It was now her lifestyle. So she felt tremendously better, and she's kept it off. So
that's awesome. And just listening to you, Dr. Georgia, you're talking about the words that you use when you're talking about nutrition, weight loss, that with your patients. And I think it's great. We kind of have a running joke here. My doctor doesn't need to tell me I'm fat. I know that. I see it every day in the mirror when I'm getting ready for work. And, a lot of people, as we've discussed here, the reasons for being overweight differ, and someone who has depression or some type of mental illness, that's their way to get out is through eating. The last thing they need to hear from their doctor that they trust so much is that they're fat. So I like how you're using lifestyle and that kind of thing. So with that being said, are there other words or can you give some examples of what you could say to patients so that the patient doesn't feel like they're being belittled because they are overweight?
Yeah, there's a number of things. One is I ask them if you're eating, or snacking, or like that late night snacking, can you stop and ask yourself why you're eating? Are you eating because you're alone, so you're lonely? Are you eating because you're stressed? Are you eating because you're dehydrated? You're actually, not having enough water? Hold on, I've got to look at my sheet here. Are you, or are you angry, or are you tired? It's called HALT. Are you eating out of habit? Are you eating because you're angry, emotional, lonely, or tired? And you kind of stop, and it helps them, if they think of the word HALT, to stop eating like that. Then they can kind of stop and analyze why am I eating like this?
Right.
And tell them that, when if it's 8 o'clock at night and you're thinking, oh, it's time for some ice cream, then you've got to change your state. And so I'll say, you've got to, if you're starting to think, I've got to have that ice cream, I really want it, your mind automatically is in this state. And so I want you to do something to get out of that state. That might be doing some wall push-ups, just 20 of them, to get into a different state.
Oh.
And then drink some water, and it helps them to shift their thinking, to get out of that habit of having something at night. The other thing is that I tell them that it's not that you can't, it's that you don't. It's not for me to tell a patient that they can't have their ice cream at 8 o'clock at night or their dessert.
Right.
It's that they don't want the diabetes. They don't want the weight gain. They don't want the insomnia. And when you use those words of, oh yeah, the doctor, she didn't say I can't have it, but do I really want it? No, I don't. I don't want to. You change their mental thinking, and it gets them thinking. It gets them out of that vicious cycle. So those are a couple of things that I use to help with that mental, because a lot of this is just mental. There's one more thing. Can I add one more thing?
Absolutely.
So, I call it a vacation meal. Let's say there's a wedding and the patient's, it's like, but I'm going to this wedding and there's going to be all this stuff. And I want to have the cake. And I said, well, okay, this is a vacation meal. We're going to call this a vacation meal. And what do we tell our kids when they want something? It's 1, 2, 3. That's enough for me. So because I don't want them to be thinking that, going down the mental route of, oh, I can't have it, and then they become depressed and angry. I don't want that. Right. But I also don't want them eating the whole big piece of cake or trying to grab the biggest piece. So I take that cake and allow yourself 3 average size bites. 1, 2, 3, that's enough for me. Push it away. Now you're not going to be angry or feel deprived, but you're also not going to be mad at yourself because you overate and you feel sick. But you had just a little bit, and that makes it okay, and you're not going to beat yourself up for it. So those are the 3 things that I use when it comes around food.
That's true. What about you, Dr. Kris? Do you have anything to add to that?
Yeah, so I would say go for 2 things. If they're craving something cold, go for the ice cold big glass of water. And if you feel like you need flavor, throw in a lemon or a lime, whichever way. Or on the opposite side, those people sometimes at night that feel like they need something sweet or whatever, I say go for the hot herbal tea and see if that takes your mind off of really needing something. As Dr. Knapp said, sometimes it's just that they're dehydrated and they need more fluids. And sometimes just doing either the hot or the cold based upon what they're craving will help calm some of that down.
Okay. Yep. Good. Well, I do want to, I want to stay just on weight loss just for a few more minutes, but I want to shift it to talk about adolescence. We know, just looking at what society paints for our children, and of course, the 3 of us have been young teenage girls, and they make young teenage girls think that they have to look this perfect, that kind of thing. And a lot of times that does lead to eating disorders such as bulimia, and anorexia. So how would you, how could a doctor ask that patient, or what would be some signs or some symptoms that they may be having that would alert the doctor to that they may be faced with a young woman who's having problems with eating disorder?
Well, For me, I think it's a lot of times they're actually coming in that case, they're coming in because they're not having a cycle. They've got some menstrual cycle amenorrhea that's going on. And then we're able to connect that there's actually an underlying either hypoglycemia or blood sugar type of issue. And then we get into the, what are you eating? And they're not, or they're going down that pathway. So that's kind of how I see it. And then it's, it's working with the parent and the child themselves, the teenager, to pull out of it. How about you, Dr. Kris?
Yeah, and I would say adolescents are probably our most challenging population, right? Because either they want to tell us everything or they want to tell us nothing as providers. Because they're like, my mom and dad made me come here and just do what you need to do and I want to get out, right? Or they're going to fill us in on everything that's going on. And I actually think it's a really good conversation to have with adolescents at the first visit, just identifying, what do you eat? How's your sleep? And really doing just a general overview as that patient's entering into your practice. The other big thing that we see with these young women, and I know this is a little bit of a tangent, but the use of caffeination, right? And if they're not sleeping well, what are they doing in the afternoons? Is they're drinking caffeine to stay awake. And so that's impacting their wake-sleep cycle, which is also impacting the way that they're eating or some of the choices they're making when it comes to food. So, really having a good baseline on getting an established, okay, what is your normal? And then as you're starting to treat and see this patient, if you're recognizing, they're coming in and they're looking really, really thin, or, mom and dad are noting things are changing, then you've got to start asking those questions. So how are you still, what's your diet like? What are you eating? A while ago, I used to tell this story that I was working with this young teenager, and we were talking about making good, healthy food choices, and we were talking about the different vitamins. And one day she came in, she was so ecstatic. She's like, Dr. Kris, you're going to be so happy and proud of me. I have found this wonderful thing that has B vitamins in it. And I'm thinking, I wonder what this is, And this was when they used to advertise 5-hour energy. And it would say that 5-hour energy is filled with B vitamins. So she, as a teenager who wanted to have extra energy to stay up and study and be slim and fit and all of these great things, thought this was the best thing on earth. And so, going through that educational process, but it may advertise that, but if you actually really look at the chemicals and the components of what's in 5-hour energy, it's not the best choice. So again, I think having those good conversations and educating our patients, especially our adolescents, on what good choices are and what healthy meals look like.
Right. Something interesting for them. And so with that being said, you're talking about making the young female feel comfortable in your office. And have your female patients or your adolescent patients discussed with you maybe some current concerns in your office setting that they felt like could have been done better for them? Or, have you had anyone give you an example, or is there something that you've actually done in your practice that would make that adolescent feel better when they came in or more comfortable being there? Any thoughts, Kris?
I think a couple things. I think, talking to them where they also, and with their parents, when you're establishing that first visit, giving autonomy to them and having them be a decision maker along with you and their caregiver, their parents, I think starts to set that stage for good open communication. Listening to what they have to say about how they feel about the treatment plan that you're coming up with, or what you have found in your assessment and your exam. So I think that piece becomes really, really important to get them to be comfortable moving forward with you.
Yeah, for me, definitely sometimes, when the parent, and typically it's the mom, is there with the teenager, and sometimes the mom can be kind of dominating. I make it a point to really focus on the teenager in front of me, of asking them, looking them in the eye and asking them questions. Even though the mom may keep butting in and putting in her opinion or cutting the child off, I'll still redirect and look right at the teenager and try to to pull them out, so that they can understand that this is between you and me. I know your mom's here,
Right.
and but this is between you and me. And sometimes it's really nice because sometimes the mom will look at me right when they walk in and say, "Can I be here?" And I will immediately look at the teenager and say, "What do you want?" Because for me, it's okay either way. It's how comfortable is that teenager
Right.
with the parent being there. So I leave it to them, and I think that gives them some confidence in saying yes or no. I don't.
Right.
So,
Right.
Yeah.
And kind of like you said, gives them ownership of their body. That's what it is. It's theirs, and they can help make that decision for their own care. So there are times when treating adolescents that you have to discuss, especially with girls, are they sexually active? When did their periods start? Those kind of things. And you've asked the parent to leave the room. What do you do? How do you ask that first? Because like you said, Dr. Nab, the mom that's always there butting in and that kind of thing. How do you ask them to leave? And then when you ask them, if they refuse to, how do you handle that? Who wants, Kris?
I was going to kick it to Dr. Nab
No,
first.
okay, Dr. Nab, we'll let you go.
He was on a roll.
That's
Trying to think, I've been doing this almost 30 years. I don't think I've ever had a parent refuse. Here's we all have our personality. And if you've done Strengths Finders, my top 5 and maybe it's number 1 is harmony. So I am confrontation, or that is really, really hard for me to do. So to confront a parent would be, it would be really, it's hard. But I've never had a parent actually say, "No, I'm not going to." So it's usually pretty respectful in that sense. Dr. Kris?
Yeah, I don't think so as well, which was why my immediate reaction was, I think, and I think that, here's the other piece. When parents are bringing us adolescents, children, whatever it is, they're coming for a reason, right? And they're looking for us to provide good care. And I think there's also that mutual, and I think it's more so when they bring us adolescents and children, that there's that piece of trust, right? And so when we're moving through this and we're having conversations with them, whether it's we ask them to leave or stay or whatever the scenario is, I do think there's a level of mutual respect. But I think we also have to be really conscious, right? Like if we have a minor and we have to make sure that we have that caregiver parental permission to examine those children or adolescents, that's also something we have to be cognizant of as providers.
Right. And I know that this is a women's health panel, but I just want to add a little bit of risk management in there. It's unfortunate, I think, today that our doctors face more challenges just in not in giving care with patients to make sure that, this goes right or that goes right. And, unfortunately, we are seeing more people accusing the doctor of things that didn't happen. And this is to all doctors, you really need, if you're in the room with a different sex patient, you need to have someone to be in there with you, whether it be a CA or, your front business person. Do either one of you have a suggestion that might make it easier to have that there to keep the patient from feeling uncomfortable because there's 2 people in the room with them? Any thought on that?
Yeah, I think it's always a good idea. If you think as a practitioner that you need to have a standby in the room, to just say and introduce, this is my assistant, they're going to be in here helping me.
Absolutely.
And just making sure they're not in a location that might make the patient feel uncomfortable. If you have a patient that's wearing a skirt or, that they might feel like somebody might be looking inappropriately, that they're just standing, in a place that doesn't actually put the patient in a compromised position or feeling.
Right. How about you, Dr. Georgia?
Yeah, same thing. I think that when it comes to HIPAA, where I have to be really mindful is the age again. That now at the age of 18, as soon as that teenager turns 18 years old, the parent can no longer have rights to any of the medical information on that child. And what's really hard is when I have an 18-year-old who's a senior in high school, the parent brings them in, and the parent's sitting here, and I can run labs on that patient, but I look at the parent and I say, but I can't send these to you. You know, that I have to, you know, this is between me and your 18-year-old, even though they're still living at home. There's this HIPAA, you know, real balance that we've got to go through. And I always make sure that, and it's part of just our intake, that we have consent. If they're 18 and under, no matter what their age is, if they're 18 and under, I've got the parents' consent to do labs, to do chiropractic, whatever we're doing. So that consent is really important. But that 18-year-old, that's really where you've got to be careful.
Okay, thank you for that. So we're just going to take a different turn right now, just since we have talked about you know, some of the things that our teenage patients do face, and I just want to talk about you know, some of the patients that we do care for, unfortunately, have had different traumas in their life, whether it be mental abuse, sexual abuse, physical abuse, whatever. And, you know, I can see where someone who's new to chiropractic, you know, not really understanding what a chiropractor does when they come in to see the doctor, and how, you know, if they've had that trauma, how they would feel uncomfortable with that doctor touching them or whatever. So in the years that you've taken care of these young patients, was there anything that helped you to see, or maybe the patient may have said to you, that alerted you to that trauma so that you could make that patient feel more comfortable in your office setting?
For me, I mean, my intake is 17 pages. It's pretty detailed, so it's going to come out in my intake for me. But so it usually comes out on that initial intake, and that initial, because my initial consult is 1 hour, so it'll usually come out if there's any flags there that I need to be aware of. So, but even before that, you know, and maybe this is just how I am. I was raised very conservative. So I have always talked to the patient. Like if I'm going to do an anterior move and I've got a big, even if it's a big busted woman, I'm going to say, I'm going to cross your arms over here. We're going to hug as I'm doing blah, 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 this and this. So I'm verbally telling them if I need to, and I don't undress my patients, but if I need to do a low sacrum coccyx adjustment, I never do anything internal, but I'm explaining, listen, I'm going to touch a little bit low here. We're going to do some soft tissue work. So before I do anything, I tell them, hey, this is what I'm going to do. So then they're not shocked.
Right. So it doesn't come up from behind them. How about you, Kris?
Yeah, and I think the same thing is true. The history is really where it comes down, right? And, you know, there's a lot of things that patients can tell us that, you know, initially as providers may not be alarming to us, but one really important thing, Lori, is none of us as chiropractors were ever trained as being trauma-informed practitioners. And so many of us can miss some of these signs and symptoms that these individuals are actually telling us. And so as a provider, you know, when you're talking about sleep with your patients, some really easy areas to further investigate are, you know, how are you sleeping through the night? Do you have any nightmares? Do you dream well? And asking those questions in a variety of ways. You know, do you have any difficulty feeling safe at home or, you know, when you're outside? Any feelings of depression or any past or current problems with alcohol and drugs? You know, do they feel isolated from other people? Now, you know, we say this, and trauma can be in so many different forms. And we look at what we all just went through, right? With COVID, that's traumatic for a lot of people. And so the isolation piece, you know, for some really had big effect. Problems with anger or irritability or really strong emotions, you know, all of those pieces can be areas to ask some other questions or further investigate if you're hearing a yes from your patient. And again, some of those things are not always in our intake forms as chiropractic practitioners.
Right,
And
right.
so we could miss it.
Yeah, yeah. And I do think that's important that, you ladies are talking about telling your patient, I'm going to do this, I'm going to do that. And I know that you've seen some of your patients for as long as you've been in practice, and you still continue to do that. And I think, that coming from a patient standpoint, I think that is very important, because that trauma, like you said, Kris, could have happened just 2 years ago, that you might not catch it on when you first start seeing the patient, because everything is fine. So my other question, the other thing I want to bring up is, we were talking about having the parent leave the room with the adolescent child. I just food for thought out there for me. When we're treating our patients, and I think Dr. Kris, you brought this up, talking about treating the patient as a whole. We do. You're not treating the patient because they only have back pain or neck pain or whatever. They are a whole person, and that person has to be treated. And I think today this has been brought more to our attention as far as handling or knowing the culture of our patients when we care for them. Because there are some cultures that you will see in your practice that the head of the household is the one that makes the decision for the patient in the story, And so, you have to think about, how are you going to handle that, because that is a different culture. So have either one of you had to deal with a different culture and explaining to them why they needed to leave the room, or because you needed to be alone with the patient? Was it hard for you to, maybe, I don't like to say put your foot down, but that's probably all that comes to mind right now. So have either one of you had to deal with any of that type of culture?
I don't think I have. Not that comes right to mind.
Mm-hmm.
Some other areas, though, were females that perhaps weren't, like you said, weren't able to make the decision. And with that, also couldn't show their skin, right?
Mm-hmm.
Or
Mm-hmm.
were not able to disrobe. And so there were conversations about how can you safely and effectively, as a practitioner, right, really do a good exam if perhaps, you're wanting to look to see if there's any abrasions or bruises or things of that nature. So some of it is, really being culturally aware. And I'm going to say that again, Lori, that's another thing as chiropractic practitioners, and it all really depends upon when you entered into practice and were in chiropractic school. But a lot of us weren't trained on how to ask those questions and say, okay, is this safe for me? And to do this and not, how do I want to say, offend your patient by asking.
Right. Because there again, that goes with the whole patient, where their culture from. And, I didn't realize how much different culture was in the United States until we moved from Alabama to Iowa. I thought everybody was the same, but it's a whole different culture here. And I would just suggest to doctors, if you have an employee that's a different culture in your office, do a lunch and learn. Let them teach you about their culture and how the best way would be to handle that patient, what the culture is as far as touch and explaining different things. And then if you don't, check with the leaders in that community and have them come out and educate you and your staff, because to me, that's just a better way to care for our patients when we can do that. So now we're going to move on to our menstrual cycles. Sounds like a bunch of fun to talk about. And if there are any guys listening, they're going, oh my God, aren't they? We know that to be true. So one of the questions we got was the importance of cycle syncing. So why is that important? Dr. Nab?
By syncing, I was trying to decide what they mean by syncing. Are they talking where they have like a regular 28-day cycle? Or are they talking about syncing with other women that they are around?
There was not a lot of explanation there. So why don't we go with the first suggestion?
To harmonize their cycles?
Yeah.
You know, one of the biggest things I see when cycles are whether it's amenorrhea, dysmenorrhea, or they're having very heavy, excessive cycles. I'm still going to go back to the hormones and blood sugar, because if you look at something like PCOS or even endometriosis, the underlying issue there is metabolic syndrome, and with that, that's insulin resistance. So there's no fixing the PCOS. There is, you've got to get the blood sugar in balance. And so I have two handouts, and on one of those handouts, it's my dysglycemia handout that I go over with most of my patients, because most of the patients I see have blood sugar issues. So that handout, I walk them through this handout, and I tell them, okay, so here's what I list: what normal is, how they should normally feel through the day. And then it says postprandial, that means after a meal, their blood sugars start to kind of go up and down. And if that continues, they develop insulin resistance. And so I have the symptoms there of what that looks like. And the question to always ask your patient is, do you experience any change in energy after a meal? Because a patient needs to understand when they wake up in the morning, they should just wake up and be ready to go, lots of energy, and that energy should maintain until evening, when it should come down. And as cortisol is going down, melatonin's coming up, but their energy should stay very stable through the day. But if they experience any type of fluctuation, especially after a meal, that's a red flag that they've got some level of dysglycemia, whether it's hypo or hyper or insulin resistance. What your patients come in and tell you is, hey doc, I've got fatigue, or I've got mood issues, depression, anxiety, or they're in pain, or they're losing their hair, or they have sleep issues, or these hormonal issues. And so anytime, you know, they come in with those symptoms, your flag should be, let's check these blood sugars. Because once you get the blood sugars under control and in balance in their diet, then a lot of times the hormone issues will clear up, and their hormones, their cycle will begin to sync. It will fall back into place. And so to me, blood sugar is one of the key things to sync, or to get their hormones back into place. And then there's one herb that I'll use, especially if they have a lot of irritability, a lot of breast tenderness, a lot of cramping. Chaste tree is by far the #1 herb that you can use with these women to clear up those symptoms, because those are a sign that their prostaglandins are too high. They've got an excess there. And chaste tree is just this beautiful herb that upregulates. It helps to balance LH and FSH. So it's talking to that pituitary gland to balance that LH and FSH, which then helps to balance all those downstream hormones. And it helps with the natural production of progesterone, and helps to balance that progesterone estrogen hormone. So they can use chaste tree along with the blood sugar to really get those hormones back into sync and clear up a lot of those symptoms. Because I tell my patients, my young female patients, one, you shouldn't know that your cycle is coming. It should just come, and then it should be 3 to 5 days. It needs to be clean, and then boom, it's done. And so it shouldn't linger for this 1 or 2 weeks. You shouldn't have a lot of symptoms. It should be clean. And so any of those symptoms, you know, we get this idea that PMS is normal, but PMS is not normal. Any symptom that's there is your body saying either something needs to come out or something needs to come in. And a lot of times it's what needs to come out is the sugar, and what needs to come in is maybe some herb like chaste tree to get those hormones back into sync. And my success rate is that the vast majority of my women, within 3 to 6 months, their hormones are beautiful. They're back to how they should be. And so some of that depends on how much insulin resistance, how much blood sugar issue we really have going on. It can take longer, but my experience is in 3 to 6 months, and they are humming. So, Dr. Kris?
Yeah. So same thing, and really truly, I actually talk about this in some of my lectures with practitioners, because it's really helping your patients maximize their hormonal power, right? And so when women are in tune with what's going on with their menstrual cycle, and we can talk about all the abnormal stuff, because that is really important. And like Dr. Nab just said, it's not normal to have menstrual cramping. It's not normal for any of those things. But meanwhile, most of the general population thinks it's normal, right?
Right,
but,
right.
When we're looking at our women, I often say that actually having knowledge about your menstrual cycle and knowing where you are hormonally, you can actually use that to your benefit. So like looking at different types of exercise or movement, as Dr. Nab educated me on today, and making that choice based on your menstrual cycle actually can be beneficial, because we actually do know, and I'm going to throw in just a hair of a caveat here. If our women are using any sort of birth control, some of this goes out the window, depending upon what type of birth control they're using. And again, because remember, they don't ovulate, and we can be talking about adding more estrogen or progesterone, just dependent upon what they're using. But looking at when a female is having her menstrual cycle, a lot of times they're really tired, right? There's the fatigue component that comes with it. So that's not going to be when they're using this high powered, like you said earlier, Lori, flipping tires, kind of exercise. This is the time to, use some yoga, use some deep breathing or movement therapy that really they like to do. As they finish their menstrual cycle and they move into more of the follicular phase, the idea is now you can start ramping up, do some of those high intensity things, especially if you're training. Some of our women that, are looking at doing 5Ks or are trying to compete in other things, now is the time to use that and use that power from your hormones to ramp up. And, again, during the ovulation phase is when women truly do have the most power, because they get that spike in testosterone. They feel very strong. But during ovulation is also really, really high time that they can actually injure themselves. So they have to be careful, because there's a strong correlate with the hormones and injury. On that down phase, again, that's when progesterone starts to get high, you get closer to the menstrual cycle, and they start to fatigue a little bit. So that's when you can start, maybe lowering the amount of weights you're lifting and maybe increase the reps, or looking at different modifications. With that, this is great to talk to your adolescents about. So talk about spinning the positive to the menstrual cycle. If you've got girls that are athletes that are in basketball, or and they're really trying to be strong and improve, this is a great conversation to have with them. The other piece is, I always talk about not just thinking the exercise piece, but also looking at nutritionally what your body needs during this time, because when women are syncing with their hormones, the other thing is, well, what do you feed yourself? Because, a lot of times as women get toward their menstrual cycle, they crave carbs, right? And so they'll binge on carbs, when actually your body doesn't need that then. You should be really focusing more on, and maybe even some good fats at that time. And really at that ovulation mark is when I say, okay, that's when you want to like up some really good fats. And that will hopefully prevent you from wanting to binge on those carbs. Now, what I often tell women, if they're a carb binger, as you're powering up after your menstrual cycle and you're maybe doing some more exercise or more movement, you can add a little bit more carbs there, because you'll burn it with that extra exercise or movement. So that's my take on syncing, and how we can educate our female patients on using their hormones to have more power and strength.
Dr. Georgia, that one herb, was it chasteberry, CHASTEBERRY?
Chaste-tree, chasteberry, Vitex is another name that it's used as. Yep.
Okay. And
so one more thing, Lori.
Yes.
And that is, encourage your female patients to use an app to watch their cycle. There's some great free apps. The one I've been using it over 10 years. They don't go away. And it's another one of those awarenesses of where you're at, of tracking your cycle. Right. So use an app to watch where you're at.
So you were talking about, blood sugars, either hypoglycemia or glycemia or hyperglycemia. So prior to or is it part of the patient's care plan that you do like a glucose tolerance test on them, or there's certain labs that you will check prior to the patient starting the care plan and then along to see how those labs improve?
Yep, absolutely. All my patients get labs.
Mm-hmm.
So I do a pretty thorough panel. Depending on the patient, if I'm running hormones or not, that's going to vary. But I always look at, for blood sugars, I'm looking at their fasting glucose, fructosamine, insulin, C-peptide, their triglycerides,
Mm-hmm.
as well as their A1C. Those are my key markers initially and just my initial intake. One of the first places you're going to see blood sugar issues is actually in their triglycerides. If their triglycerides are running over 100, then they're already showing signs of not being able to manage carbohydrates and sugars very well. The last place you're going to see it is on the A1C, because that A1C tells us over 90 days. And when it shows up there, their blood sugar issues have been going on for years.
For years.
So, and in these younger individuals, more of what I see is hypoglycemia. And the one lab marker that can point towards that is your LDH, which is actually a liver enzyme. But when your LDH is 140 or less, and I use LabCorp, but when it's 140 or less, that is your red flag that they have hypoglycemia. And then you can look at the A1C, and if it's running low or low normal, and you talk to the patient, that can be your flag that, okay, we've got some hypoglycemia. And the concern there is if they don't manage that hypoglycemia, it will eventually flip into insulin resistance. So, and we see that a lot in our teenagers and our young adults. We see a lot. And their symptom might be, well, I never eat breakfast because I feel nauseated in the morning. If they have nausea when they wake up, they've probably got hypoglycemia because their blood sugars have dropped too low. And what they actually need to do is kind of force themselves to eat a little bit. And that might just be a couple of bites. But what they'll find is if each morning, if they eat just a little bit, within 3 to 5 days, that nausea will dissipate and go away. So, but they've just got to work through that those first few days to get over that. And then you've got to work with them on, okay, we can't go too long without eating. We've got to keep these blood sugars healthy. And those patients, the last thing that they need to do is fasting, because fasting is only going to aggravate their hypoglycemia. So.
True. So now let's just turn over to infertility. Dr. Kris, you do specialize in pelvic care. So when we look at infertility, are there dysfunctions, or what type, let me rephrase that, what type of dysfunctions are with the pelvic area to the pelvic floor area that could cause infertility in your patient?
These are really good questions, Lori. You know, it's fascinating because one of the things that I think I learned really early in practice is that a lot of times when our women come to us and they're talking about trying to get pregnant or conceive, or they talk about their journey and they haven't been successful, it always seems that their journey has always focused right around the pelvis, right? And no one has really honed in on, and going back to treating the whole patient, the whole physiological journey of this individual. And, you know, I think that's the first key for practitioners, is when you are really honing in and focusing in on the history, to really think and really ask questions about all of the pieces that can be impacting these women. But, you know, from a biomechanical structure, and really thinking about the anatomic structures that we have as females, and really honing in as a practitioner. Obviously we look at the pelvis, we look at the sacrum for restriction, hypomobility, subluxation, whatever it is that you would like to term it. But one of the areas that we often forget about is always looking above and below. So like the TL junction and the correlative of the motion relative to the TL junction and the structures that attach. And so I always tell providers that when you're assessing your patient, there's not one magic button that we can press and help our patient get pregnant, right?
Right.
We have to be thinking about the entire biomechanical structure and how is that impacting the mechanics of the pelvis, whether it's posterior, whether it's anterior, whether it's the pelvic floor. My favorite, and I always joke about this in my seminars because I love to put up, there's a picture of the uterus and there's a ligament that attaches to the sacrum. And at some point, we all dissected it when we were in anatomy labs in chiropractic school, but it's the uterosacral ligament. And a lot of times, patients will come into us and they'll say, Doc, I've been told by my practitioner that my uterus is tipped, right? And a lot of times we'll go in and we'll palpate the sacrum, and what's going on with the sacrum? The sacrum is also either subluxated or nutated in one direction versus another, or it favors one side relative to another. And so as a practitioner, I often say, use those clues that patients are telling you and help that with your diagnosis of these patients, and really take time to look at the biomechanics of the pelvis.
And with the biomechanics of the pelvis, are there certain exercises that a patient could do at home to maybe not hurry, but be more, can't think of the word, to help that injury, so say, get better so that their infertility would get better?
So pelvic floor, if we're talking about pelvic floor dysfunction, it's interesting because I don't have a really good correlative with pelvic floor dysfunction and infertility. It can happen, we can see it. I always say pelvic floor dysfunction happens at any age. We actually know young girls in their teen years actually can experience pelvic floor dysfunction. So really focusing in on making sure whatever exercises they're doing doesn't have greater force or impact to that pelvic floor. And, a lot of times when women lift objects, they'll hold their breath. And one of the big things that we know about the pelvic floor is that the diaphragm and the pelvic floor move together. So they're like a piston, right? So if you breathe in, the pelvic floor and the diaphragm are going to move with you, and they're going to move out when you exhale. And so when women are lifting, if they're actually tightening their pelvic floor to lift up, they're actually doing a disservice to their pelvic basin. And so a lot of times I will tell women, even if it's not even just lifting, like if you're doing crunches and you're using a medicine ball, a lot of times you can feel that pressure on your pelvic floor. So anytime you can feel that, that's actually not a good option. So that means you need to find a different exercise or a modification of that exercise. I know a lot of women will do planking for core, because we need great core strength when we're talking about pelvic floor. And planks can actually cause a lot of pelvic floor pressure. So the modified plank is actually a good choice when I'm thinking about that. But I just want to make sure that I'm clear that I don't have any good data or statistics. Maybe Dr. Nab does on pelvic floor dysfunction and infertility. I think there's maybe two different things happening there with these patients. So,
for me, instead of fertility, more so for incontinence is a big issue.
Yeah.
And so the two things that I check with them is the pubic bone, and I'll adjust the pubic bone if it's out. And you can do soft tissue adjustment. So this is one of those where I'm talking to the patient. If I need to adjust their bladder or their uterus because it's prolapsed, then I either use their hands, or I say, listen, I'm going to go right above your pubic bone and I'm going to put pressure, and you're going to be doing this as I'm doing this, so that we adjust either the uterus or the bladder to help pull it and help kind of balance the structural issues that are going on there. And you'll hear it. I mean, it's amazing when you adjust that, you can get an audible out of that region, and it helps tremendously, especially more so with incontinence issues with those patients.
Okay.
Yeah, actually, Lori, it's funny because I actually say that it's in my experience, it's more embarrassing for women to talk about leaking than it is to talk about their menstrual cycle. For some reason, I don't know if it's culturally ingrained or there's almost like a level of shame that goes with talking about I leak. And so as a practitioner, asking those questions is so important, and you know, putting it into your history or your initial intake, because we actually know that there's a correlative. There's some excellent research that talks about the correlative of women that are coming in and reporting low back pain that are actually also leaking with pelvic floor dysfunction, not leaking because of anything else neurological, but that correlative is there.
Okay.
But they think it's normal, right, Dr. Kris? I mean, they think, oh, it's just
absolutely.
I get kids, so it's just normal, or I'm getting older. It's like, no, wait a second. No, it's not. Let's see if we can use chiropractic and fix this. And it's really quite successful.
Awesome. Awesome. So we're not going to go too much into treating pregnant women because we don't have enough time with that. But just thinking about your pregnant patients, when you are treating them, what just kind of safety concerns for that patient go through your mind as you're taking care of that patient, let's say in the exam room? Georgia?
Okay. Chiropractically, my table, I have a flexion distraction that has a drop piece. So I will tell you, my female patients love my table because I can put them on their stomach and the tummy just drops through there, and then I'm stretching them. They don't ever want to get up
I'm
from
sure.
the table. Because how often can you get on your stomach when you're past 4 months? So that's adjusting is really the other thing. I guess this is just how I adjust. I do a lot of kinesiology. I'm an old AK doc, so I'm muscle testing and using kinesiology. But with me, I don't put them on their side. I use drop pieces, but the breast, especially 6 months on, they're full, and so you don't want to be doing a P to A because it just hurts. So I will definitely, anteriors are huge for them. Plus, I mean, they're carrying so much weight anyway, so you tend to see a lot of anteriors on the thoracic region in those patients. And when you adjust those, boy, I mean, they feel really good.
Oh, I bet they
It's
do.
tremendous. And I tell you, one of the questions they ask is it safe? And I'm like, absolutely, up to the day. It's so safe, and it helps you, and it helps the baby, and it helps your labor. It makes everything just flow so much better when you're in place. So I think the important thing is communicating how safe and how important it is to get adjusted through the whole pregnancy.
Absolutely. Yeah, I had a friend of mine who was pregnant with quads, and she didn't miss a chiropractic visit at all during her pregnancy. And she took them to term, and she truly believes that it was chiropractic that got her there.
Well, along with that is, everything's getting pushed up. So what do they have? They have hiatal hernia, right? They have reflux. And so I tell them, here's how we can adjust this to relieve your reflux. And you can do this to help relieve that reflux because, no, you don't have to deal with that through the whole pregnancy. So it helps with reflux as well in these patients in the pregnancy. Yeah.
Dr. Kris?
Yeah, so, it's interesting. I'm going to echo all those things that Dr. Nab said. But I think the other thing is too, and I know I keep going back to the history and I keep going back to the exam, but to me, those are really important. And, not taking for granted that our patients are moving through this without challenge, right? And, not being afraid to ask them when they come in, how many weeks are you? And verifying that in your documentation. Also documenting if they are far along enough where they should be feeling the baby move, right? Are you feeling the baby move? Are you doing your kick counts appropriately? If your patient's coming in and now saying, hey doc, I'm getting like new headaches, don't miss that opportunity to try to take their blood pressure, make sure they're not moving into preeclampsia. Again, as practitioners, we see them much more than their OB sees them in the very beginning of their pregnancy.
Absolutely. And don't you find that sometimes, well, I think as women, we talk more openly to our female doctors anyhow, because you can relate what we deal with. And I think that patients are more apt to talk to their chiropractor, but long before their medical doctor, because of the relationship that you build with your patients. You know, it's incredible, the trust that they have with you, and you know, just the information that you can get out of them for maybe the 15 or 20 minutes and that they're in your office. It will make a whole change, you know, in the way that they're cared for. So I think it's great. So anyhow, now we need to move on to old people. That would be me. So I hope I didn't offend anybody, but yes, that's me. See, this blonde here is not, you know, I should have gray, but I don't. Anyhow, so we know that women with menopause have a lot of different symptoms. So, you know, there's hot flashes, there's irritability and hair growing everywhere, and the list goes on and on and on and on. So, Dr. Nab, when you're talking about menopause and the symptoms with the chastenberry that you talked about, now, would that be a good combination during that phase of life? Or are there other things that would be better for them during that phase of life?
Sometimes I tend to lean a little bit away from chaste tree. I'll use some other herbs like black cohosh is really good. Tribulus, especially if they've got kind of a lower testosterone or dryness or lack of libido. Tribulus is a beautiful herb, and actually Tribulus can help a lot with the hot flashes or the night sweats. Tribulus works well. Sometimes you can find a nice combination formula. I'm not going to say the brand, but I have one that just, it's got a nice blend and it works very, very well. But it's got the black cohosh, B6, some nice, it's a nice balance that works really well. You still go, you know, not to beat this up, but blood sugar always plays a part. The three biggest causes for hot flashes in these menopausal women that I've found is sugar, alcohol, and stress. And a lot of times they'll say, oh yeah, I usually drink, you know, some wine or have alcohol at night. And I'm like, well, let's cut that out. And, you know, for a couple of weeks, and let's see if these hot flashes go away. And oftentimes they'll calm down just by taking the alcohol out, because it's a big trigger. So you look at their diet, and then, yeah, there's herbs that are beautiful for that.
Okay. Dr. Kris?
Yeah, so interesting, because Dr. Nab, you had me laughing a little bit about the alcohol and the stress, right? So a lot of times they'll say, I drink the alcohol because I have the stress, right? You know, we tell them to stop the alcohol, but we also just provide them, you got to figure out the stress too, right?
That's right.
There's 3 hours for meditation at night.
And exercise is not the answer.
Movement. It's movement.
Movement. That's right. Movement.
Yeah. Well, sometimes that stress is coming because their spouse is snoring a lot and they're not sleeping. And so they're getting frustrated. And I'm like, don't be afraid to go into a different room to sleep. You know, that's okay. Because it's more important that you get sleep than being stressed about, oh, great, I've got to listen to so-and-so snore tonight. And, you know, go to another room. Give them, sometimes patients just need permission, right, to do something. So give them permission. Okay.
Yeah, right. Yeah, that's right. Tell them my doctor said I could do this.
Yes.
So, Kris, do you have something else to add to that?
So going back to the menopause conversation, you know, it's interesting because one of the things, and we were chuckling earlier about you know, about periods and menstrual cycles and all of those things a little bit when we were saying, you know, doctors sometimes, especially chiropractors, shy away from asking that question. And so we actually know, and the literature supports this, the literature is magnificent, talking about the shift in the age of menopause that we're actually seeing in women. And a lot of that has to do with the age of their first menstrual cycle or menarche. And so a lot of times providers don't think about asking, you know, a 48-year-old female, when was your first menstrual cycle? Because why would that matter? But it actually does. And so the literature tells us and shows us that if a woman menstruated before the age of 11, they were 80% more likely to have premature menopause. And on average in the US, it's and again, it's generalization, on average about 51 years old is when we see women moving through having menopause or moving through menopause in the US. But there's a lot of contributing factors that are actually moving up that age. So we need to be conscious and asking some of those questions that we might not think have value, but actually do when it comes to identifying.
Mhm.
I agree, because our risk here is the earlier they're into menopause, then the higher their risk for osteopenia and osteoporosis, right?
Mhm.
So I tell
Mhm.
my female patients, my goal is that for you to hit menopause sometime in your 50s. And sometimes they'll say, I do not want to be cycling in my 50s. I'm like, but let's think about the benefits of this.
Right.
Okay.
Right.
Let's
Mhm.
think about your bone health and your mental health, how much better that is in terms of putting the odds in your favor.
Mhm. Mhm.
So, yeah.
Yeah, and I think the other thing is, how about the women that have hysterectomies because they have to, right? I mean, there's a lot of medical reason why women do opt to have a hysterectomy. However, on the flip side, there are a lot of women that have hysterectomies when there's things that we can help them with naturally that can prevent that hysterectomy. So I often say, save the uterus. If you can save the uterus, you want to save it. And the reason being is that there's again, going into that instant menopause, right? There's not that slow decline of hormonal change. It's instant and it's fast. And so that actually has a really strong correlative. Believe it or not, the uterus has a strong correlative with brain health and cognition. And so the younger you are when you have a hysterectomy, the greater the likelihood and the correlative with early dementia and cognition challenges. Also when we look at that, the other piece is just like Dr. Knapp said, then you worry about, okay, earlier and what does the bone health look like? So we've got a few different components that really relate back to, women's reproductive system and really maintaining them well.
And I just want to add to that, and I'm going to steal this from you, Dr. Kris, that we have to remember when women go into menopause, their risk for coronary artery disease increases because they no longer have those hormones to protect them, which is bad. I mean, because you have all that protection and then all of a sudden it's taken away from you. And like you said, someone who surgically has that done, they don't have that digression of the hormones there, So it makes me wonder, okay, so if you've had it surgically, and along with your other family history and stuff, could you have an MI at an earlier age? And I would certainly think so.
Yeah, and we know, and it's really fascinating, Lori. So we know also the average age for MI, and the number one condition that contributes to death in women is heart disease, right?
Absolutely,
and,
yes.
And at age 51 is the same age that we're seeing menopause. And so, interestingly enough, you go back to how many women have symptoms of heart disease that may have been early identifiers. And this is all practitioners. It's not just chiropractors, right? It's all,
that is all doctors, absolutely.
And so there are things that again, going back and asking those questions can help prevent, early death in some of these females, and help them to live longer.
Right. And, we've talked about, treating the patient as a whole. And I think as, we learn as we grow in our profession that, I just lost track of thought. Sorry, gang. I had this big thing I was going to talk about and I just, okay. Oh, I know what I was going to talk about. So, and we're taught through books, and as we grow in our profession, we learn that patients are not textbook, that it's just a guide more or less. And you were talking about the signs and symptoms that, doctor can miss. And I just want to add in there, the different patient. When we're talking about our diabetic patients, that is a small vessel disease. And so if you've got that diabetes, your symptoms may not be the same. Unfortunately, we lost my husband's mom very early, and her complaint was wrist pain. Only complaint she had, and she thought it was her what's that you get? The tracker.
Carpal tunnel?
Thank you, carpal tunnel, yes, and it unfortunately was not. So, prior to coming to NCMIC, I worked with a cardiology group, and a lot of women, their complaint to me was, I've had this bra for a year and it's the tightest thing it's been in the past 3 days or whatever when they started with this discomfort. And I've actually had women complain of epigastric pain, thinking that it was reflux. So, I think that we need to, all of us as healthcare providers need to, be aware that patients are not textbook and that we need to treat the patient, not the book.
Right.
Yeah. And I think, Lori, you raised such good points about women in general. Women have a higher rate of dismissing some of the symptoms
Absolutely.
they're experiencing, right?
Mm-hmm.
And so, going back to the example you used is the wrist pain, very easy to say, I lifted something incorrectly, right?
Mm-hmm.
Or
Absolutely.
whatever it is. Sometimes we'll hear that with edema in women's legs. They'll say, you know what, I had too much salt. That's what it is, or I didn't drink enough water, when really there's something else going on. And as chiropractic practitioners, one thing that has always rang in my head was, women that are all of a sudden reporting thoracic spine pain that really don't have a mechanism, or posterior rib pain that don't have that mechanism. And so, just being extra cautious and really taking a really good history and doing a deep dive if
Absolutely. Yeah, and you're right. That history is so very important, because I think about, and maybe y'all have different thoughts on this, when a patient would come to the emergency room, they would tell me why they were there. Then I would take them to the receptionist. The receptionist got a different story. I'd take them to the room. By the time the doctor got it, it was a different story, and at times we were able to look at their history and start pulling and asking questions around that, and I just think it's important, that the doctor, if your patient hasn't been in, let's say 6 months, have them fill out another history form, because all I can speak is for myself. If I see something I don't think it's important for you, then I just won't write it down. That's the nurse in me, I guess. It's like I can handle it all, and you do treat people that way. We're just smart sometimes.
Yeah, and I think, as the chiropractic practitioner, it's that whole, you've got to document, right? If you don't document, it didn't happen. And so for all of these pieces that, we're asking, and we keep talking about some of the different questions that are really important, to make sure that they are in our notes, because that's incredibly important, not just for the treatment protocol, but for the history and long-term care of the patient.
Absolutely. Dr. Georgia?
The only thing I'd add is that I really stress to patients to know your numbers. Beyond just what your total cholesterol is, there's so much more that you could know about your numbers that you can dig in to understand your risk factors, like homocysteine, or know your CAC score, your coronary arteries calcium score. Just your labs can tell you so much, and there's things that you can dig in, like an NMR, to understand what's the risk factor here.
Right.
So do the labs, numbers.
Absolutely. And of course, I'm going to have another risk management moment here. And one thing I would tell to doctors is, if a patient is having signs of a heart attack, do not put them in a car and send them to the ER. Call 911. Muscles time. They need to get to the ER and they need to be seen. And then think about the liability that you would put your self in, or your employee that you have drive there. All my years of nursing, I've never known anybody do CPR and drive at the same time. So, call 911 and have them come in. And, I believe, I've always believed this, in healthcare, we are a team. No matter if I'm a nurse, doctor, rad tech, whatever, we are team caring for that patient. And I think it's so important that we remember the continuity of care for our patients. And, if that patient's in your office, you call 911, the medics get there, take the time, call the ER and say, hey, Miss Jones is coming to your ER. I think this is what's going on, blah, blah, blah. And there you've got that continuity of care, so we don't miss things with our patients when we're treating them.
Yep.
And then you document it, that you did all of them.
That is correct. Documented. That is correct, because if it wasn't documented, it wasn't done. But it's true, it's just true. And I think both of you can relate to this. And I want to say it's more women than men, I might get that different from my husband, but I think we have this intuition when it comes to caring for people. We don't do it for ourselves now. We're the last on the totem pole when it comes. But you know, if that doctor just has that one thought that this could be an MI, do it. Call 911. You know, it's the easiest. Okay,
I think
let's
the
see.
big takeaway on that is we've got to not be afraid to refer out. That
Absolutely.
you've got to have, and I've got a listing of different specialists. So I'm ready that when I need to refer, I'm not afraid to refer.
Mhm.
I can only do so much. So have your, the other doctors that you can work with and refer. If you have
Right.
any questions, refer it out.
Right. Well,
Patient-
go ahead, Dr. Nam. Go ahead. Go ahead.
Patients will respect you for it.
Oh, absolutely. Absolutely, they will. You know, and my thing is there again, you know, I could get on my soapbox. To me, it'd be no different in like when a doctor refers a patient to you, you should be getting copies of that chart. You know, there again, so you can see what the patient's history is, what's been done for them prior to coming into your office. And I don't know why that's not done anymore, but I have been told, I guess I better wrap it up. So any final thoughts from either one of you before we close out?
I'd like to leave everybody with one final thought. Always remember every female patient's physiological journey is different. Don't take it for granted. Always ask the full history and treat that whole person.
Right, absolutely. Dr.
And mine
Jordan?
would be, make sure if your patients know you care, they're going to stick with you
Absolutely.
through thick and thin. So always let the patient know you care. When they walk in, I look and I say, "Hey, how are you, my friend?" I call them my friend. I want to maintain that professionality, but I also want them to know that I care about them, the whole of them, not just their spine, but all of them.
All right. Well, thank you, ladies. It's been fun. We'll have to do this again because we really have more to cover, but we'll go with that. So I think I'm going to turn it over to Mike so we can close it out.
All right. First of all, thank you, Lori. Awesome job. And thank you, Dr. Petrocco-Napoli and Dr. Nab. This has been absolutely great. I really appreciate it. A lot of really good information that I'm sure our audience will find useful. So thanks again. You can keep up on new resources from NCMIC by following us on LinkedIn, Facebook, Twitter, and Instagram. So once again, doctors, Lori, thank you so much. We really appreciate you. And thank you to everybody that listened in today. We hope we'll see you next time. Thanks very much.
Bye-bye.